All right. Well, thank you all. First of all, I want to say a big welcome to everyone for attending this webinar today. I know it's not as exciting as being in person, but we certainly welcome the opportunity to still connect and to have a good conversation today. So we would like to thank our sponsors as well and their generous support. And we'd also like to thank definitely the providers who are on the front line serving those affected by COVID-19 right now. Just to kick off, we are excited to have a really great panel today to discuss medication-assisted treatment. For those of you who may not be aware or just need a little bit more background information, medication-assisted treatment is an evidence-based approach to treat opioid use disorder that includes a combination of psychosocial therapy and U.S. Food and Drug Administration approved medication such as buprenorphine, Suboxone, naltrexone, and methadone. So my name is Laura Summers, and I'm the Senior Healthcare Analyst at the Kempsey Gardner Policy Institute at the David Eccles School of Business. And I'll be moderating the panel today, and I'm joined by some fantastic folks who are working on the front lines of the opioid epidemic in the state of Utah. Our first panelist will be Dr. Lauren Prest, who is the Medical Director of the Mental Health and Addiction Treatment Services at Moab Regional Hospital. And then we'll be followed by Lori Wright, who is the CEO of Family Health Care, a patient-centered medical home community health center in St. George. Unfortunately, Mike Austin is not able to join us today and not able to participate on the panel. Unfortunately, he had something come up, but we'll move forward without him. And on the plus side, that gives us more time for dialogue and questions at the end. And if Mike, if for some reason you're on the line or able to join, definitely chime in and let us know. I'll let Lauren and Lori provide a more detailed introduction during the panel. But just a couple notes before we begin. We do invite attendees to use the chat section on their control, which should pop up at the bottom of your screen. You can use that to share any personal stories of what you're doing in your communities and any action items that you'd like that you will do to advance medication-assisted treatment in your community. There is a separate Q&A section at the bottom that you can be used to ask questions that we'll address verbally over the webinar as well. So just know that there's two separate functions, the chat function as well as the Q&A function. And at the end, our great sponsors of this webinar will take that information and make sure that it's shared with attendees. I also wanted to note that the webinar is being recorded today. And then just also note that if anyone is interested in obtaining CME credit through the American Academy of Family Practitioners, there are instructions at the bottom of this slide, very bottom of this slide, that provides how you go about receiving that CME credit. And I think we'll be sharing all of the slides after the conference today as well. So I'm going to go ahead and kick us off. I am a healthcare research analyst, so I'm definitely not on the front lines in terms of providing medication-assisted treatment and addressing the opioid epidemic. But we are getting ready to share a report that the Kempsey Gardner Policy Institute is publishing early next week on medication-assisted treatment in Utah. We're hoping to have it ready to publish today so that everyone could access it, but I'm sure, as everyone knows, now it's just kind of a crazy time. But we should have this up and ready on our website by Monday or Tuesday of next week. And I'd be happy to make sure that we share that with all of these participants as well. I won't go into a lot of background, but as we all know, the opioid epidemic is a critical public health issue that the state was dealing with before COVID-19 came crashing in, and it's one that will continue to exist after the current pandemic ends as well. So it's definitely something that our state continues to deal with and continues to face. And it's one of the, I think, largest public health issues that we as a state and as a country have been dealing with. In 2018, for example, 417 people in Utah died of an opioid-related overdose. Close to half of these were prescription-related. The other half involved illicit opioids such as heroin. And these are just a snapshot. You can also see the graph up here that shows the opioid overdose death rates by local health district. This is really just a snapshot of the fast-growing opioid epidemic in which Utah saw almost a 400% increase in opioid overdose deaths between 2000 and 2015. So to help inform future discussions and decisions regarding Utah's opioid epidemic, we received support from the Pew Charitable Trust to develop a comprehensive report of medication-assisted treatment for opioid use disorders in Utah. Our research objectives were threefold. One, it was to develop an inventory of medication-assisted treatment programs in Utah. The second one was to facilitate discussion groups to better understand the barriers and challenges to both providing and accessing treatment. And then to take this information and compile this information and present it to the legislature and other stakeholders so they would have information and data to make informed decisions about medication-assisted treatment and how to grow the use of medication-assisted treatment for opioid use disorders over time. So in terms of developing the inventory, that was really our first task, was to take all of the programs, try to figure out which ones are offering medication-assisted treatment, and develop a comprehensive program list as possible. I just caveat that by saying that this is a very changing landscape. So what we have developed is a snapshot in time, and certainly, you know, as more programs come in, as programs go out, as more physicians become licensed to provide opioid use medication, again, that program list will change. But what we tried to do is work with some partners, including the Addiction Policy Forum, which is a national group out of DC, as well as the Division of Substance Abuse and Mental Health, to obtain a list of substance use or addiction treatment programs. And then we matched those programs to a list from the Drug Enforcement Administration of physicians and other qualified health practitioners who are waivered to provide medication for opioid use disorders. So we were able to remove duplicates, we were able to add in the prescribing physicians, and hopefully, again, what we were able to do is develop that program list that really represents a snapshot in time. For purposes of our inventory, we came up with 3 classifications. Again, this was just for our sort of categorization and classification. One, we designated programs as MAT if they were programs or locations that appear to offer both psychosocial therapy and FDA-approved locations, approved medication at the same location. OTPs are opioid treatment programs. These have a separate certification and licensure that allows them to provide methadone. So we maintain that separate classification for those programs. And then we use the term OBOT, which is opioid based office treatment, to designate those programs or locations that have data waiver prescribers, but it was unknown whether that psychosocial therapy was offered on site or through a referral. So again, this is just for our own classification as we moved forward in terms of making sure we didn't have duplicate programs and duplicate prescribers. So this provides one visual representation of the inventory, which shows the rate of medication treatment options per 100,000 people compared to opioid overdose deaths by local health districts. So the number of programs or the rate of programs is in red, and then the opioid overdose death rates are in gray. And you can see how that varies by local health district. Now, I like this graph because it's a good sort of visual representation, but I always have to caveat that you have to interpret it with some caution. For instance, while Southeast Utah, Southeast Health District, which encompasses Carbon, Emory, and Grand counties, has a high number of available medication treatment options, it also has the highest need in the state in terms of being measured by opioid overdose deaths. So again, you can see that maybe the number of programs have been brought into that county in response to just the high need in that area. Summit County, for example, or for another example, is they have the second highest rate of programs, but the actual second lowest need, if we use the opioid overdose deaths as a proxy for need. And again, you could either interpret that as an overdistribution of medication-assisted treatment programs, or were they able to reduce the opioid overdose death rate because they had such a high number of programs in that area? Unfortunately, this data can't tell us that, which is why you really need to interpret it with caution. However, I think it is helpful because it really does highlight some areas of need in the state. If you look at the bottom, for example, Tooele County has the second highest need for opioid use disorder medication treatment options in the state, but also the lowest rate of availability. So again, hopefully this is helpful just in terms of understanding where those programs are located and how they're matching up with need across the state. The full report includes information or a series of additional maps that look like this, that basically show locations of different programs, the availability of different programs by different areas of the state. And we break that out in the report by looking at MAP programs, OVOT programs, and OTP programs. So again, you can see that differentiation between the different types of programs. But again, hopefully helpful in terms of providing that visual representation of the dispersion of medication treatment options across the state. So lastly, I just wanted to quickly highlight some of the themes that we heard from the discussion groups regarding barriers and challenges to providing and accessing care. Some of you who are attending this webinar may have actually participated in those discussion groups. So they were incredibly invaluable. You know, it's one thing to look at the data, but we always recognize that until you're actually hearing and learning from the people on the ground who are providing these services on a day-to-day basis, you really don't have a good understanding of where areas that lack services are, what the challenges are, what the barriers are, and what are the considerations for improvement in terms of making sure that more people across the state have access to medication-assisted treatment. So these are some of the key themes that we heard from the discussion groups, both in terms of barriers to accessing care and challenges with providing care. I won't go into a lot of detail on these. I think we'll probably cover some of them through our panelist responses, but I did just want to note, it was really interesting to see stigma pop up as one of the primary barriers to accessing care, as one of the primary challenges to providing care. And one of the considerations the discussion groups offered up in response to this was the need for more public education, more public understanding of what medication-assisted treatment is, what it's not, and why it's important to get people into this very evidence-based approach to treating opioid use disorder. So I'll close there, and we'll actually hear from a couple of our panelists who are having experience providing these services in rural areas across the state. But I did just want to again let you know that hopefully this report will be up on our website early next week. I'm happy to send out a link to Locke and others at the Rural Health Association to get that out to attendees. And I hope that really it can be used as a baseline for future studies that determine medication-assisted treatment availability and whether that's growing and whether that's growing in a way to meet the different needs across the state of Utah. So at this point, I am going to turn the panel over to Lauren Press to introduce herself and talk a little bit more about what is happening in Moab.
All right, thank you. It's really nice to be here. I'm glad this conference has gone on as planned, and I appreciate you having me here with you today. Just a little about myself. I'm an addiction psychiatrist, and as Laura mentioned, I work down in Moab, Utah, so I work in that southeast portion of the state where we see some of the highest rates of opioid overdose, and I think that was probably the impetus of my hire last year. I'm pretty new to the area down there, although I did my training in Salt Lake, and I'd gone down into the Moab area multiple times over the last several years and worked through a grant to help local communities treat patients with opioid use disorder and many other addictions. But ultimately I got hired on at Moab Regional around August of last year. And when I first came down, my initiative was to do a community survey, really get to know the area better, talk to all the community partners, talk to patients, really try and get an idea of what the needs were so that I could build a program that would fit the unique cultural aspects of a place like Moab, which is a kind of unique town. It's a tourist town. We get 3 million tourists a year, typically, not this year, obviously, with COVID. But our small town, despite only having about 5,000 people that we serve typically who are local, we often have services that have to expand and retract with the tourist load that comes down through. So when I started, I initially was tasked to meet some very specific needs around mental health and substance use disorder. You can see this chart on the slide here. This is from our most recent community health needs assessment that came out in December of 2019. And you can see that one of the top few things that people within our region had asked for and felt was not a need that was being met was addiction. So, and also mental health is a little bit further down the list. But number 2 on that list is drug use. So you can see down below where I run a few different services now out of the hospital. We started with a collaborative care clinic, so like primary care integration is another term for that, and our goal being to create a medical home model where we can work directly with primary care providers and provide consultation and feedback, because I'm the only psychiatrist in the area, and I was very aware early on that there was no way I was going to manage all of these patients one-on-one, that it would really take a collaborative approach. I also am starting a new clinic at our mental health authority called Four Corners, and we'll be supervising some mid-level practitioners, a PA, and working with one of their Four Corners APRNs. And that will be to provide kind of a parallel mental health home to work with our medical home at the hospital. Also, we've started a recovery clinic, an SUD clinic, where I see patients as a specialty provider, kind of chronically and over a long period of time, people with any type of addiction and those with dual diagnosis needs. I also do inpatient consults, and we're starting a controlled substance monitoring program, meaning kind of keeping track and helping primary care monitor all the needs of anybody that they've cut a prescription for that's considered a controlled substance. Because as Laura mentioned, many of the opioid overdoses and consequences of opioid prescribing and lots of other types of controlled prescribing are responsible for some of the overdose rates and perpetuation of substance use disorders in our state. And it's no different in Grand County. So helping providers learn more about that and what we can do to help manage and monitor some of those patients for risks and complications, and also work as kind of a preventative program is the goal with that. We're also recruiting a child and adolescent psychiatrist. I'm really excited about that, to have some part-time help down in our area as well. Can we go to the next slide? There you go. So right now, just to expand on what our SUD or our MAT resources are now, the recovery clinic does run out of the hospital, but we have worked really hard to create a partnership with our local mental health authority, Four Corners, because they have more counselors and therapists, and they work with drug court, and it seemed like the best thing, for patient care, to be serving patients out of their site. Some of that's been interrupted by COVID, so I've moved back over to the hospital and I'm doing telehealth now. But for the most part, that's our goal, is to be working on site with patients at the mental health authority. I provide MAT, including Suboxone, naltrexone, Vivitrol. I also treat other substance use disorders using medications that are not necessarily, FDA approved for, like, for instance, methamphetamine use, but there's some, moderate evidence to support their use, and so we treat using medication for other substance use disorders as well. We've also hired on a dedicated nurse case manager who has a lot of experience running a detox unit in Pennsylvania, actually, and we brought him out, and that way we can now run an outpatient detox service as well, so I can kind of be in two places at once with some trusted eyes that I know really understands the dangers of withdrawal and what do those syndromes look like. We're also doing some jail consults now, and all of our psychosocial interventions, for the most part, besides the case management piece, are being provided with the help of Four Corners. We also work a lot with community partners. I think that's a really vital part of what our services look like in Moab. And some of those recovery-specific resources include USARA, which is, I'm probably going to screw this up, but Utah Supports Advocacy Recovery Awareness, and they started out of Salt Lake, but they have a satellite in Moab as well. AANA, Four Corners has an IOP, we have drug court as well. And then next year, my big plan is to hopefully build an OTP clinic on our hospital site, which I think will really help treat more patients and reduce barriers to access. You know, one of the big benefits of an OTP is that you can treat a lot more patients with a singular provider because the programming is so supportive and structured. So that's part of our goal for next year. I wanted to comment a little bit on some of the barriers that we're facing in Moab, which I'm sure aren't very different at all from the barriers that the rest of you are seeing. But we have very few providers, of course. We're in a rural area. We have a lot of patients, and actually these days they're coming out of the woodwork. We're getting a little overwhelmed at the hospital right now with how many people with substance use disorders are coming in for help. We're still keeping up with it, I think, but I think in times of crisis, like with this COVID, I think a lot of people are reaching out for help when they wouldn't otherwise, and so we're seeing a lot more people come through. We do have a fair number of primary care providers at our hospital, but I think like a lot of places, there's a lot of stigma for those providers, and they're also very overwhelmed with treating a lot of other things that are going on. And they're not very interested in engaging with SUD services, except to, you know, refer to a specialist like myself. So that continues to be a bit of a barrier. I also think that most care systems in our country are not built for patient access, and especially when people are new to recovery, their lives are pretty chaotic. I think some of them are coming from intergenerational patterns of substance use disorders. And it's really helpful to have the lowest barriers to access as possible. So like street level access. And that's kind of what I view OTPs to be, because they're open at 5 a.m. typically. It's a walk-in kind of thing. There's a provider on site to do their intake, and you can often start treatment within a few hours. So it's really a special setting in that way. And most places don't have that kind of care access, and neither do we right now. There's also a lot of programs that, you know, require a specialized approach, like wraparound services and very specific types of behavioral health intervention. It's very man or woman power heavy, and it requires funding that just don't exist in a lot of places. And speaking of cost, that's another barrier. We have many uninsured people, many people who just don't meet that cutoff for Medicaid access. They're constantly on and off of Medicaid sometimes, where they get rewarded for having a job by losing their insurance. Or they're underinsured. They've gotten healthcare through the healthcare marketplace, and it just isn't sufficient for what they need. And then also, I think one of the biggest barriers that I see every day is medication-based. You know, at the hospital, we provide a lot of financial aid services, and so their office visit with me might be free, but then they still have to come up with, you know, $25, $50, $120 a month to pay for their medications, and that sometimes just isn't happening, right? So they are on and off medication, and they're not getting the full benefit of care. I also believe that there's a lot of limited training and understanding, and that I think that and stigma play on one another, but addiction work is a specialty, and most providers don't have the training that makes a real difference, you know. And you know, most of you may be aware that, like physicians, they really don't get any addiction training in their residencies, and it's something they have to pursue of their own interest, and that's not most doctors, I would have to say. And the other thing is that we don't have any standardized oversight for programs. So you'll notice that from place to place, state to state, treatment programs look really different. And I realize it's a much more in-depth conversation that's needed to talk about this particular topic. But what makes a treatment program legitimate and high quality, I think, is still a matter of opinion rather than being evidence-based. And I hope someday we get to a point where all of our programs are based within some common evidence, so that we can treat patients better, and that they can count that their dollars that they spend in their care really mean something long-term. I also think a lot of providers just don't really know how to talk to this population. So there's a lot of layers to the way training has implications and how people are treated, but those are just a few of those things. Stigma, of course, I'm sure we'll talk a lot about that today, but I think it's multi-generational. It's in communities, families. Patients themselves are often the most stigmatized toward themselves, and so they are less likely to be engageable in care. And then when you think about settings like the legal system, where medications like methadone and Suboxone are still banned in a lot of places, and that really can make the difference about whether people can regain their self-sufficiency and take care of their children and all of those things. Part of that is misinformation as well that keeps people from accessing care. I think I spend a lot of time, especially with new patients, talking about what addiction is and what it has meant for them in their lives and how they can apply their new knowledge to that stigma that they carry in their minds. And then, of course, it's worth mentioning that during COVID, there's a huge barrier to community level care. All these places that typically wrap around and help people and have walk-in services are just not available right now. And telehealth can be really limited. I've got a lot of patients that don't have smartphones. They don't have computers. And how do they get in touch with me? I'm emailing some of them. I'm meeting them in the parking lots. There's stuff like that going on right now that, just it's new for us. Yeah, and then here, a couple more thoughts. For Moab specifically, I think we're in the middle of applying for a lot of grants. Money is always necessary, and that's where we're at. Our programs are really new. We're always looking for collaborative efforts. I work a lot with like USU Extension, and we're really trying to pull people in as much as we can. And then, like I mentioned, our hospital is going to do an expansion, and part of that will hopefully be to build our OTP by the end of next year. And I think, that just goes back to this whole idea that the setting in which we treat these people is really important because of that stigma in particular, that they really need a place where they can feel safe and they can feel that there's low barriers to access and that they can contact you, because it takes almost nothing for these patients typically to walk away from a care opportunity. And then creating cultural changes around addiction care. So I talk all day long with people about what is addiction and how can we build compassion. And I think early on, I remember thinking that with trainees, that the first thing we have to teach people is compassion and understanding. And then from there, we go on to teach them other skills, like how do you set boundaries respectfully, and how do you kind of play that good parent with people with SUD, because most of them are really new to so many aspects of self-sufficiency. And then community collaboration, like I've also mentioned. I could not do the work I'm doing in Moab without my many community partners and my many interdisciplinary partners. I am the only physician doing this right now in my area, and that by no means could be done at all without the nurses I work with and the social workers and everybody else that comes to the table with me every day. Thank you.
Thank you, Dr. Press. That was fantastic, and really appreciate you taking the time kind of walking through both some of the barriers that you're facing specific to Moab, as well as some of the opportunities that you're leveraging. So at this point, we're going to turn it over to Lori Wright, who will provide us an overview of what they're working with down in St. George. Lori does not have any slides, so I'm going to keep it on this version. But Lori, we're excited to hear from you.
Great, thank you. I think I want to just echo everything that Dr. Press just said. I think we've been involved in this in St. George for about 3 years. we had a great vision at one point as an agency that we wanted to start offering MAT services. And we are a federally qualified health center, so we get some grant funding from HRSA, and they gave us a little nudge to move forward in this. And so as we were recruiting a physician, I really made it a point as I was talking to them to ask them about how they felt about MAT work. And somewhat miraculously, I stumbled really upon a physician who was coming out of the Moab area, had been doing MAT work there for 10, 15 years and was interested in moving to St. George and wanted to continue doing that work. And so we met and we hired him, and his name's Dr. Mahana Fisher, and he's been a catalyst for us in this work. And then also, I think we had another great experience with having a nurse practitioner who has her psychiatric credentialing, and so she's a Psych PRN. Also, just knocked on my door one day, literally, and wanted to come work in St. George. And then we have a social worker who has an extensive amount of experience in substance use disorder. So all those people together have helped us at Family Healthcare really move forward with our MAT work. We serve about 15,000 people in St. George, Hurricane, and Cedar City. And our MAT services serve all that area as well. And we've done some pretty interesting things. We've made some mistakes, and we've learned a lot, and we're really honing in on a program that we feel is really great for our patients and really great for our staff as well. So we had about 350 people in our MAT program about a year ago. And we've done a lot of work in the last year to solidify our program, make it a lot better, helping us determine who should be in our program. We're using a lot more ASAM criteria and different things to determine if people are really ready for us. We're not like Dr. Prest, who has, all that ability to do that full range of care. We're really an outpatient MAT program in primary care. And so we wanted to make sure we were having patients who were patients who would be the most successful in that program. And so right now we have about 270 patients in our MAT program, less than we had before. We've actually had a pretty closed program for about a year, trying to get down to doing the right kind of work with the right people. And we've created what's called MAT Core. And what happens now when a patient comes in to receive services from us, they will meet with a physician or a PCP, sometimes it's a nurse practitioner, and that Psych PRN and a social worker. And they do those meetings together. They do inductions together. And then we also have the great services of, like USERA. We have Southwest Behavioral Health Center that we partner with really actively in our program that help us also extend those services. We work with court support services down here, outreaching up into the jail system as well. But our program is, it's just like what Dr. Prest said, and with lots of stigma, even starting the program with our providers themselves, helping them shift from MAT or opioid use disorder to being a disease, and really thinking about it that way, looking at standard of care for treating that disease and not being so, fixated on abstinence being the only way to really treat an addiction. So we've done a lot of work as an agency, and I imagine that you probably wanted Dr. Fisher here and I'm the second choice, but I think a lot of administrative work has to be done to help that be stabilized and move forward, and make sure that you're keeping that, that long-term goal in mind as you stumble and work through some of the problems that come with that. In our community, we're just like Dr. Prest, we see a lot of uninsured. When we opened our doors to MAT, we really thought it would be our 15,000 patients that we would see, but that proved not to be true. Partially true. They are our patients now, but they also came from all over the community as soon as they heard that we were offering this service. And many things are heartbreaking for us, and many things are amazingly energetic and positive. I think for one of us, one of the challenges is in primary care, you deal with disease in a different way than you do in an addiction-based setting. And So getting used to failure with patients, death of patients, some of those things have been really hard for us. Understanding how to be, like Dr. Press said, really compassionate and empathetic, as well as learning then after you really become that, how to structure and help them also find structure in their addiction has been a challenge for us. I think funding is always going to be a challenge. And I think that access to medication is something that we certainly struggle through with our patients, and wanting to make sure that their access to medication is never a limiter in their success of this program. We've done some really cool work administratively too. We meet a lot, talk about patients a lot. We've removed some of the harder things from that provider team. They don't make financial decisions with patients. They don't ever have to say no because of finances. Those things are happening away from that group. But we do everything as low cost as possible, and also want patients to participate in community health centers. One of our fundamental premises is that people should participate in their healthcare, and part of that is through payment. And we do that with as low payment as possible, and try to make it so that that payment isn't the barrier, but that they're also participating with that payment. And that's something we've really had to learn. Initially, we were really forgiving, and found that in our world that it was important that they can pay, and that's one of the ways we assess readiness. And it sounds a little hard-nosed, but we also are, I think, incredibly generous and forgiving. I think ongoing, one of my big things probably matches what Dr. Press was saying a little bit, is I wish that it was easier for people to get to a data waiver so they can prescribe. But at the same time, that makes me nervous, because I think that MAT work is a lot more than just giving someone a prescription. And we require that behavioral health component right alongside of it. And we feel very strongly that that's one reason we're successful. But I think there's all kinds of levels of care that people need. And that's another thing that we're working really hard on, is helping people get to Vivitrol or other options, Sublocade, and different things that help them be a little more just stable. And sometimes it is harder on people to just take that daily medication. And again, I'm an administrator, so I don't have all the doctor talk, but I do know that when I talked to our providers, initially they were all very skeptical, and except for Dr. Fisher, of course. But they all have come full circle and really understand how beautiful MAT work is, the wonderful giving back of people their lives, and how powerful that medication is in helping them get to that place where they can re-establish relationships with family. We see a lot of that, and our providers are pretty excited about that. Trying to think of some other things. When we talk about addressing MAT in our world, in the community health center world, and just in St. George and Cedar City in general, there's things like transportation are a tough thing for these patients, and we're working on trying to find some solutions to that with the partnership with SUU and UROC. We're also, a lot of them deal with social determinants of health concerns, not just medication and therapy, but stable housing and domestic violence and some of those other things that you can imagine. That's about all I have. Back to you, Laura.
Great, thank you. No, that was fantastic. It's really it's great to hear different perspectives from those who are on the ground and the challenges that you're facing day to day. So we do have a couple questions. So I think I'm going to jump straight to the questions, and then I have a couple too that we can round back to at the end. But the first question that came in was about the research behind medication-assisted treatment and non-medication-assisted treatment. Is there a significant evidence that shows medicated treatment is best? And if so, is methadone best? So I don't know, I'd love to toss it to you, Lauren and Lori, to see what thoughts you have. to that particular question about, why is medication-assisted treatment evidence-based, and then is there a particular medication within those that are FDA approved that seems to work better than others?
Okay, I'll start. I think we have to talk with some nuance, right? Because there's lots of different types of addiction. I think if we want to talk about opioid use disorder specifically, which is typically what people are referring to when they talk like about MAT, we're talking about Suboxone, methadone, Vivitrol. There's robust evidence that those medications are helpful for people. I think when you look at opioid use disordered folks, they will relapse with upwards of 90+% rates without treatment. So, and specifically, I'm talking about without Suboxone or methadone. And so we have really strong evidence that engaging patients with those two treatments in particular can raise their retention rates in treatment, save their lives. They won't overdose, they won't die, and also help with their long-term functional and wellness goals, meaning they can stay out of the legal system, they can have jobs, they can keep their families intact, and they can move forward in their lives. And opioid use disorder may be a little bit different than some other types of addiction in some ways, because certainly when we think about meth and alcohol in particular, abstinence is still the name of the game. Those medications, those drugs are directly deleterious to the brain, and they are brain damaging, is what I mean. And so that's not true with opioids. Even though opioids are very dangerous to use, we can't necessarily say that they are damaging the brain on a biologic, neurologic level, cognitive level. So with that in mind, I think that speaks to some of the reason why people get stabilized on Suboxone and methadone, and that it evens out some of the changes that do happen in the brain at a receptor level, and it helps people move forward. And that some of them may do well to come off those medications in the future, but we normally see better outcomes when people can stay on those meds longer term. I'm talking at least 2 years. That's kind of what we see timeline wise, if not longer. I mean, I've had patients that are on it decades who I probably think will be on it lifelong, right? But other people, depending on the severity of their illness, some of them just need detox or a short period of time on medications, and they actually do okay. But that's the minority actually of people that do need it only short term. Vivitrol has good evidence as well, but certainly the retention rate is not as high. Methadone still outpaces those other medication options, and it probably has something to do with the full agonist mechanism of that medication. I think what we know really about opioid use disorder is that there's not one medication that is like, the golden ticket. And so some patients have really long histories of really severe heroin and fentanyl use, and Suboxone is not for them. Like, they just will not get better with that medication. They will continue to use both or none, or drop off the map or die, and methadone is better for them. Still, we have people who are even more severe in their illness, and methadone isn't even going to cut it for them. And that's why once you start getting to know, this may offend some people to talk about, but that's the stigma, right? Is that there are some places that are appropriately, I think, considering safe injection sites. And that means pharmaceutical grade heroin being provided to people so that they can come in and use in a clean, supervised setting with heroin that's not cut with all these other chemicals that's going to harm them. And for some people, that's what does it for them. And it's also an access point for treatment engagement. I'll say that as well. So, my message is, I guess, that there's not one thing for everybody, but you have to individualize treatment. And opioid use disorder is special, okay? The other substance use disorders like alcohol, you got to have abstinence, to get better. But that being said, there's good evidence for Vivitrol in that group, naltrexone orally as well, that helps reduce cravings and also reduces the amount of alcohol use that people use if they do relapse on that medication, because it modulates some of the euphoria and rewarding sensations they get when they use alcohol. There's some possible evidence that's coming out around Vivitrol and methamphetamine. There's less strong evidence for other medications than methamphetamine, but there's some, and I do see some good outcomes with people depending on the medicine we're talking about. So anyway, I'm going on and on at this point, but really it's that these substance use disorders are not like a one size fits all, nor are they biologically or mechanistically the same. So you really have to know what you're talking about and get some good advice about the treatments that exist.
That's great. Yeah, I was going to say that is something that we heard sort of very loud and clear from the discussion groups that we ran as part of our report as well, was just that it is a very individualized approach because everyone is coming at it from different life experiences, different places with their substance use disorder or opioid use disorder. And so I think that's maybe one of the benefits of this is that there are a different range of medications that you can try and prescribe and find the best fit for individual people. So Lori, is there anything you wanted to add?
Yeah, I was thinking about that a little bit about how really MAT is a lot about harm reduction and how important that is. And then the gateway into services. We have been shocked actually by how we would say 90% of our patients in MAT have co-occurring mental health diagnoses that are either not accurate or have never been diagnosed. And so often just getting them into any kind of treatment starts to help them get better in a holistic way that's different than if they continue to just try and do the same thing that they've never been able to do. And I know the addiction program still with all that, I mean, not addiction, any addiction treatment program deals with those things, but I've been really impressed with how that entry into something that they think is just going to help them. And sometimes they think they're just going to come and get a medication and it will be somewhat easy for them, but it is never easy, as we know. And then helping them get to diagnoses. We've talked a lot about that, how when someone says, wow, this is what I'm feeling, and understanding better. And I'm sure Dr. Prest has similar experiences, and people, I know for myself with the medical diagnoses, and when you can't get a medical diagnosis, it's incredibly frustrating, and not being able to understand what's happening with yourself emotionally, I'm sure is even worse. And so that's another thing I just wanted to add.
Great. So a second question that came in was, do you have any recommendations for the best ways to speak with clients about substance use disorders? I think both of you mentioned that as one of the challenges is even, opening up that conversation and helping them be aware of the need to get treatment. So I don't know who wants to go first. Maybe we'll start with Dr. Prest.
Yeah, I think it depends, again, on the setting. I mean, if we're talking about primary care, or maybe you're a counselor and you don't have a lot of experience working with this population, I think your earnest and open interest in them, in any patient, goes a long way, so asking real and open-ended questions about their lives and feeling like they know you a little bit before, I'm not saying self-disclosure, but that they have some comfort with you before you have those conversations with them. And then, I think it's also your right as their care provider to be knowledgeable about their lives. And so I think it should be part of every assessment that people are doing, just to say, hey, do you use any substances? What's your relationship with alcohol? Like, I don't even really ask people if they drink anymore. I just say, how much do you drink? And people go, oh, I don't, or they say, about a fifth a day, or something comes out of nowhere, So, I think it just begins with questions that are open and earnest. You don't want to. I think these patients, if they are people who use substances, are very well trained by society and their families, and the medical system to fear that question in some ways, and they will pick up on the stigma that you portray. And so if you have some judgments about substance use, I think it's best that you explore those before you come at a patient, because they're going to pick it up off you at the drop of a hat, and they'll shut down and they'll lie to you or whatever. You'll never see them again. So it's good to be cautious, but it's still good to ask. And especially if you're someone who has the interest in this topic at all, I'm sure you're going to be someone who can ask those questions in an intelligent and reasonable way. So I think it's a balance between, you know, checking your own judgments, but also being someone who's interested and compassionate about this group. So we need people like you who are going to ask those questions and help engage people in care. And I think sometimes people are afraid to ask the questions because what if somebody says, yeah, I'm an alcoholic, then what? You know, then you're kind of in this corner around what are you supposed to do now? But you should ask anyway. And if you don't know the answer, just say that. I don't know, but let me see what I can figure out and who I can ask to give you a call. Or maybe the next time you come in, I can have you meet with so-and-so, you know, like just ask the question, but follow up, you know, and don't be afraid to hear information that maybe you're uncomfortable or unfamiliar with.
Lori, anything you wanted to add to that?
I love that whole idea of asking the question. I know when we originally started talking about this in our provider group, they were like, oh, we don't have this problem. Our patients don't have this problem. They also don't think sometimes that our patients smoke or drink at all. And so sometimes those questions are hard to get providers to ask, and even to get in the primary care setting, a medical assistant to feel comfortable asking them the way Dr. Press was talking about, without judgment. Sometimes just matter-of-factly is fine, and sometimes they struggle with even that. So getting accurate information is really interesting. And one thing we've learned in primary care, what we thought we knew before we started doing MAT about any kind of substance use by our patients was probably not a complete accurate picture. And the better we've gotten at asking that question and being more compassionate and less judgment as people give us their answers, we're learning a lot more. I did data waiver training, and I'll never forget the psychiatrist was saying how, I think similar to maybe what Dr. Press was hinting at, is that they probably are using other things. And so he would say, you go in and you do your screen, and he would always say, hey, so what am I going to see? I've done the drug screen, so tell me what you think I'm going to see. And he says, when they can start disclosing everything to you in that way, he says, that's when you start really making good progress. And something that we've had to really train staff is that opioid use disorder comes with a whole bunch of other things, and we're trying to help them with this thing, and we don't want to punish them for doing, for having that drink or smoking that joint, which is something that, for me, I've had to learn that, and to really talk about them as humans with a disorder has been really good for me.
I would also add that, the more you learn about addictive thinking in this population, the more you realize that sometimes patients, I don't think they even really realize that they're lying to you when they're lying to you. Because they're just so used to downplaying and minimizing their substance use for themselves too. And so even patients I've known for years, sometimes, I'll look at their drug screens or whatever and be like, oh, there's THC this time, like what's going on there, and the patient will be like, oh man, I totally forgot about that. It wasn't like their intention to be, to be lying. And so many providers I talk to feel slighted or offended, or they feel insulted that their patients have lied to them. And I think it's so much more complicated than that. So, trying to take your ego off the table is really important with this group. I would also say that if you can learn MI, motivational interviewing, I would. There's a lot of courses out there. It's actually one of those things that a lot of medical people learn, and I think a lot of social workers and counselors learn. Not a therapy modality, so it's something your nurses can even learn. It's just a communication style that helps you practice this non-judgmental kind of rolling with resistance. How do you mirror people? I mean, it really gives you a lot of practical skills for dealing with patient groups that are really sensitive.
Great. Go ahead, Lori. Thank you.
No, I just was going to say, I hear that a lot from everyone that is doing this work. And I love the idea of taking the ego off the table. I think our team that we've put together, one of the things I love about them is that they'll say regularly, we're constantly getting to know our patients at a different place and a different level every single time they come in. And the other thing that we've seen is a lot of trauma with this population. And we've done a lot of EMDR with them because again, is that whole idea that you talk about with trauma-informed care is not, it's what this person's experienced, but not what's wrong with them, which I think is really powerful too.
That's great. So we've had a lot of great questions come in. Unfortunately, I think we're getting pretty close to time, so we're not going to be able to answer everyone. So I'm just bringing up this slide that has all of our email addresses on it. So if we don't get to your question in this webinar, definitely feel free to reach out to any of us regarding your specific question. And I think we'd all be happy to be able to respond offline on that. So I'm going to close with maybe one or two more questions. We'll see how many we can sneak in. But there was a question about medical marijuana, which I thought was a little bit of an interesting spin, particularly as the state has just approved medical marijuana, and we're starting to see those dispensaries come up. Is there any, they were wondering what your thoughts are on medical marijuana as an adjunct or alternative in prescription-based opioid addiction treatment versus street opioids. So any thoughts on medical marijuana?
Sure. I tend to take a little issue with the term medical marijuana. I think it's misleading to patients. I think there's moderate evidence for treatment of some medical conditions, in particular some pain syndromes, muscle spasticity. There's some, CBD-based products there's some rare seizure disorders that have some support from an evidence-based perspective. But don't get me wrong, I'm not like so diehard evidence-based that I can't like conceptualize the idea that it could be helpful. I think we just have to be really careful about how we perpetuate the evidence around marijuana because it's not very robust. I think we also have to keep in mind that we're talking about kind of two different populations, people with history of substance use disorder and people who don't. I think the more information we learn about marijuana as a cure or a treatment, the less convincing I feel about it. I think it tends to complicate people's clinical picture and worsens a lot of their symptoms, especially psychiatric conditions like PTSD, anxiety, psychosis, bipolar disorder. I think the evidence is fairly clear that marijuana is not helpful for those people. I think people who have no history of addiction and live, lives without complications from mental health or very serious medical illnesses, I mean, I don't have a horse in that race. I think whatever, do as you will, But I think when it comes to opioid use disorder in particular, there have been some studies, and the studies show, and the initial studies were sort of promising. It showed that THC could decrease people's pain awareness or the pain levels that they experience, and so there was a lot of hope that you could reduce the prescription opioid use of those people. I think subsequent studies are showing less potential that that's true. That we're actually showing that the use of opioids rises, because whenever you do a research study, right, there's a certain amount of time that people are monitored for. And so when they're short-term based studies, they do see that some of those pain levels go down. I will also note though, that within those studies, those people had to be high to get their pain levels down. So it wasn't like you were getting pain reduction without complication. So it's not like you could have those people go to work and get in their car, they were stoned. So you can't, it's not like a great outcome. But the longer term studies show that opioid use rises. And so that jives a lot more with what we understand about how marijuana works, because it still triggers that reward pathway, just like every other controlled substance and illicit substance. So in my mind, I have a lot of caution about medical marijuana being helpful within an addiction setting. And I really discourage my patients from using it. Can't hear you.
Oh, thank you. I was going to say, Lori, anything you want to add to that or just closing remarks? So, all right. Well, we are at the top of the hour. I just want to again thank Dr. Lauren Prest and Lori Wright for joining this panel today. It was a great discussion. I apologize we didn't have a chance to get to everyone's questions. But again, feel free to reach out to us if you have any lingering questions or concerns, and we'd be happy to respond to those individually. So Thank you all again for participating. And if you have any questions, please reach out to either one of the panelists or to one of the people at the Rural Health Association. Stay healthy and happy. Thank you.